से खाली मैन बच गया मैं। बोलिए कैसे है।
मैं तो बढ़िया हूँ। आप कैसे है?
मेरा चल रहा सर। अपना काम जो है नीचे से काम कर रहे हैं। आगे
अच्छा।
चले जा रहे हैं। आपके फोटोज आते रहते हैं। हम्म।
फारक भाई, आपका भी चेहरा दिखा दो। आप दिख रहे तो चेहरा नहीं दिख रहा है।
या दिख रहे हैं ना अभी। व्हाट रवि यू आर डाइटिंग हाँ।
यस यस।
या लुक्स तो हाँ।
डाइटिंग एंड एक्सरसाइज बोथ।
Vasanta, can you ask the person to mute everybody?
సంజీవ్ 1 minute సంజీవ్
నడుస్తూనే ఉంటాయి అన్ని మాకు ఇవన్నీ ముచ్చట్లు నడుస్తూ
गुड इवनिंग डॉक्टर संजीव।
गुड इवनिंग सर।
हाँ, कैसे है भैया?
बस सर आप लोगों का दुआ है, चल रहा, लाइफ गुजार रहे।
नहीं 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 यार, हमारी दुआ नहीं, ऊपर वाले की दुआ है।
आप भी ऊपर वाले हैं ना, करीमनगर में ऊपर सो ऊपर ही जाता ना, को जाता ना
नहीं
वो।
नहीं 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 नहीं। हैदराबाद वाले ऊपर वाले होते हैं, करीमनगर वाले नीचे वाले होते हैं।
वैसा हम समझ रहे थे मगर ऐसा नहीं है कुछ। अरे
क्या
आप
है
भी
भाई,
अटक
आप
गए।
डबल एक्शन कर रहे हैं क्या? दो दो आ रहे हैं,
क्या है
इमेजेस
कि
दो
नहीं
दो आ
मालूम
रहे हैं।
तो। दो दो आ रहे बोले तो एक आदमी तो दिख रहा, बस बाकी दूसरा कौन है नहीं मालूम मेरे को।
आपका बड़े
हाँ।
नहीं, एक एक इमेज जो है सामने आ रहा है, एक इमेज जो है पीछे आप बैठे हुए कुर्सी गिरसी दिख रहा।
मैं कार में हूँ सर, ट्रैफिक में फंस गया।
ऐसा?
हाँ, आई एम इन द कार स्टक इन ट्रैफिक। लैपटॉप खोलेंगे बोले तो लैपटॉप में मुश्किल है रास्ते में, तो इसीलिए फोन पे हूँ मैं। अब अलग अलग आ रहा ना।
नहीं, पहले एक फोटो दिख रहा आपका घर का, पीछे पूरे मेमेंटोस दिख रहा और सामने
अरे
आप
वो
अकेले
क्लिनिक
दिख
का है
रहा।
सर, घर का नहीं, क्लिनिक का है वो।
हाँ, क्लिनिक का है वो।
तो बैकड्रॉप ऐसा बना के रखा मैं।
वैसा? तो
हम्म।
इसीलिए दो दो इमेजेस आ रहे हैं।
हाँ।
गुड इवनिंग द्वारक। गुड इवनिंग डॉक्टर अले साहब।
हाँ, गुड इन सर।
गुड इवनिंग।
రవి సార్ గుడ్ ఈవినింగ్ సార్ రవి సార్
गुड
रवि
इवनिंग
sir,
रवि सर।
yeah,
गुड इवनिंग ब्रज बाबू।
Ravi sir, I made. Now you can share, sir.
गुड इवनिंग संजीव सर को भी, संजीव सर को।
नमस्कार नमस्कार ब्रज बाबू, कैसे है।
ठीक है सर, ठीक।
आपको देख के खुशी हुई, अच्छा।
Ravi sir, we made you host. You can share your slides now. Yeah, start a screen share. Okay, sir.
Am I audible?
Yes,
Yeah,
Ravi bhai.
very much.
But I am not visible.
You're
Okay,
not
okay, I will
visible.
be visible now.
Yeah, you are visible now.
Okay. Just let me once, Dr. Vasanta Kumari madam, you tell me, I will start.
Yes, sir. Just 1 minute.
Yes.
Good evening, Dr. Ravi Wankhedkar, sir.
कैसे है संपत राव साहब?
Yeah, this is Dr. Sampat Rao.
कैसे हैं आप संपत राव साहब?
अच्छा है साहब. We are lucky to hear your teaching also, apart from the IMA stalwart.
Yeah,
You make
that happens
everybody
with
so-
all IMA leaders.
Yeah.
We all forget that we are clinicians first.
Yes. Well, with your oratory skills, you make everyone so effective in the any forum. So your teaching also must be same effective.
Thank you, sir. Hopefully. I have been teaching for last 35 years.
Okay. The bottom surgery used to be very not so important in the previous years.
Yes.
Now it has gained so much of academic aspects of the bottom surgery.
Yes, very true.
Good evening, Sampath.
Yeah, good evening.
Good evening, Dwarak.
Good evening,
Good
everybody.
evening, Dwarak. Good
Shall
evening,
we
Vijayaraj
start, sir?
sir.
Shall we start? Ravi sir, shall we start?
Yeah, I'm ready.
Good evening, madam.
Good evening. Kali Prasad join అవ్వలేదండి.
ఒకసారి ఫోన్
We
చేయండి
will
మేడం.
inaugurate the session, Dr. Vijay. Okay? Yeah.
ఓకే.
Namaste. Namaste. Good evening to you all. I am Dr. Vasanta Kumari, Chairman, Scientific Committee of Telangana, IMA. I welcome you all for today's Wednesday's webinar on proctology, common anorectal problems by our beloved and eminent speaker, Dr. Ravi Wankhedkar, sir, Professor of Surgery. At the outset, I would like to thank Dr. Ravi, sir, for accepting our invitation to speak on proctology. I now request Dr. Vijay Rao, our Honorary Secretary, the IMA Telangana, to inaugurate the session, followed by Dr. Dwaraknath Reddy, sir, President IMA elect, and Dr. Sampath Rao, sir, past President IMA Telangana, to speak few words. Sir, thank you. Dr. Vijay.
Thank you so much, madam. Respected Professor Dr. Ravi Wankhede sir, to chair your session, Dr. Sanjeev Singh Yadav sir, and Dr. Dwaraknath Reddy sir, President elect, and Dr. Sampath Rao sir, past President. I think our President, our beloved President, Dr. Kali Prasad, is going to join. So, and respected IMA, esteemed IMA members and delegates. Sir, at the outset, I would like to thank you for accepting our invitation to deliver a talk on very important topic, sir. Sir, you remember, sir, I have visited CGP conference. Your hospitality was excellent, sir. Thank you once again. Thank you so much, sir. And to tell you a few things about sir, sir was involved in many social activities apart from medical practice. is the founder coordinator of Mission Pink Health, which is an ongoing community health project for adolescent tribal girls, in which more than 250,000 girls have been benefited up till now. He has started Shit Shiver Davakhana, that means a free clinic for farmers at his farm, for poor farm workers and laborers. He had conducted many medical camps in remote tribal areas of Satpura. It was Sir's idea to start Ubari Abhiyan, a helping hand from IMA Dhule to the drought and hailstorm affected farmers. As a result of his relentless efforts towards making IMA stronger, he was chosen unopposed as a presidential candidate for IMA, national presidential candidate for IMA for the year 2017 and 18. Sir, this scientific webinars we have started since last year, sir, because as a part of our activity to provide latest scientific knowledge to our members, we have formed a committee, scientific committee, and which is headed by Dr. Dynamic Lady, Dr. Vasanta Madam. She is chairperson, and secretary is Dr. Sampath sir. Ever since the committee came into the functioning, sir, every week we are organizing webinars and providing new scientific developments in our medical field by inviting eminent speakers from all over the country, sir. Today, we are really fortunate to have you to speak on this very important topic, sir. Thank you, sir. Thank you so much. We welcome you, sir, to this today's webinar.
I request Dr. Kali Prasad to join and speak few words. He is our IMA President Telangana. Dr. Kali Prasad, you're welcome.
Yes, madam. Good evening, madam. Good evening to everybody. Sorry for late joining, as I was traveling to Hyderabad. Good evening to Ravi Wankhedkar, sir. Nice to see you in Zoom meeting. My secretary, Vijay Rao, and all the members who have joined today's Zoom meeting. I really appreciate Vasanta Kumar madam for taking a good subject as a webinar, Proctology. I also congratulate Dr. Sanjay Young Yadav, today's speaker. Thank you very much. I request Vasanta Kumar madam to continue the same spirit to come with more topics. Thank you, madam.
Thank you, sir. Dr. Dwaraknath Reddy, sir, our President-elect Telangana IMA, to speak few words.
Good evening, everybody. I think to have such a wonderful, multifaceted person today giving his important topic, because everybody used to think of proctology is nothing but piles, but there are several things now they are doing. It has become a sort of almost something like a super specialization and taking care of several aspects of it. And as already been mentioned, Ravi is a clinician first, and then a leader in IMA, and then being a social activist, and he is doing a lot of human service in the area of Dhule. And I really congratulate Vasanta for bringing Ravi today, being the speaker for this important webinar. And I'm sure that we are going to get as enlightened with this his talk. And on the same lines, we are having with us here the local person who is also equally doing excellent in this field, in this particular area, none other than Sanjeev Singh Yadav. So I once again thank Ravi and then Vasanta for organizing this excellent webinar. Thank you very much.
Thank you, sir. I now welcome Dr. M. Sampath Rao, sir, our past IMA President of Telangana, to speak few words, and followed by Dr. Ravi sir's presentation, and to be chaired by Dr. Sanjeev Singh Yadav. Yes, sir. Dr. Sampath Rao, sir.
Yeah, thank you, Dr. Vasanta. I already spoke about our eminent speaker, Dr. Ravi Wankhedkar, and I appreciate Dr. Vasanta in organizing such a beautiful programs. It is very difficult to run with her, and we cannot cope up with her the speed of the activities and the activities she does. I congratulate her for all her efforts. I don't want to take much time. Thank you, Dr. Vasanta.
Yes, sir. Thank you, sir. I now request Dr. Sanjeev Singh Yadav, our past Honorary General Secretary, IMA Telangana, and he is a general surgeon and he himself is also a anorectal surgeon. Kindly chair the session, Dr. Sanjeev. Over to you,
Thank you,
Dr.
madam.
Sanjeev.
Thank you, madam.
Welcome, Dr. Anuradha from Bangalore.
Thank you, madam.
Thank you.
Excellent activities done by Dr. Vasanta and group. I welcome Dr. Kali Prasad, Dr. Dwaraknath Reddy, and Dr. Vijay Rao, and most important, today's speaker. He is just not a speaker. He is a charismatic polymath person who is well versed in all fields. Environmentalist, as a speaker, as a teacher, as a good friend, and the subject he is dealing with today, proctology, is something which we both picked up at the same time. This is something which is very new to medical field, because in our medical field everybody was more busy with liver, intestines, gallbladder, appendix, and all hernia. But we thought this particular subject needed a lot of concentration, because lot of quacks in this area were tying threads or putting some acid, doing something. It is my privilege now. I'll give a brief introduction of Dr. Ravindra Sitaram Wankhedkar. This is original name. Nobody knows him by this original name. Ravindra Sitaram Wankhedkar, born on 21st September 1963, to a school teacher, Mrs. Bhagirathi Bai Wankhedkar, and late Sri Sitaram Wankhedkar, who was a freedom fighter. Ravi is a perfect example. As I told you, a polymath, a terminology coined to address persons whose expertise or knowledge spans varied subjects. He did his MBBS and MS General Surgery from BJ Medical College. After that, he stuck down to Dhule, his hometown. That is what is the most important factor in Ravi's life. Although he is an international man now, he started his practice in Dhule and served the people all around Dhule, and working as a assistant professor, and ultimately he landed into the lap of IMA. It was an asset for IMA because he has done so many things. I don't need to enumerate whatever he has done. But his role as a past president, as a chairman of IMAMS, in many other capacities has been very, very spellbound. And he has given us a path which many new presidents are following. And this man is such a charismatic person that every day he is doing something, either in his farmhouse or in his hometown, or meeting some senior professors, going around Maharashtra, going around India, and ultimately now he's landed as treasurer of WAMA. It gives me an immense pleasure to introduce the charismatic person, Dr. Ravi Wankhedkar, although Sitaram has to be added in between, because if I talk more, he will not get a chance to speak. Now I request Dr. Ravi to please talk to us the gist of anorectal surgery. Thank you, Vasanta, and thank you, Dr. Ravi. Please start your lecture so that we can listen to your lucid words. Thank you very much.
Thank you, the learned chairman and my brother Sanjeev Bhai. And I was so happy that Sanjeev is going to chair the session, because no better person and a senior proctologist from the beautiful city of Hyderabad, the very respected president of Andhra Pradesh, Dr. Kali Prasad Garu, the president-elect and our senior IMA leader, and a good friend, Dr. Dwarak sir, the past president, Dr. Sampat Rao, my elder sister, whom I fondly called as Akka, and so many other leaders. I have Dwarak sir said that Vasanta did a good job in catching hold of me. But let me tell you, Dwarak sir, she was after me for last 3 months. that every time, every week she used to call me and say, Ki, sir, when are you going to give your time? Unfortunately, last few months, a year or so, I've been tied up with certain other things which I am unable to spare more time within for IMA also. But Telangana, Hyderabad, being past AMA chairman, and I've seen actually the work of, not only seen, I've monitoring the work of Dr. Vasanta Kumari Madam, who has been working very sincerely and very dynamically and very silently. So I couldn't say no to her. And the most important thing is that being a teacher, whenever I get a chance to give a lecture on academic topics, I usually don't let it go. I am thankful, Dr. Vijay Rao, the secretary, for your kind words. Hospitality is there. That is what IMA should be, because everybody has enough in our own practice. When we move out, what matters is the love and affection which we are able to share with each other. And I am so happy, and I want to congratulate the IMA Telangana State Branch for continuously holding weekly webinars on academic problems. And I hope this will continue, and which will be beneficial for all of us. Coming to today's topic, common, I thought I would just give an gist, as Sanjeev has rightly said, in very brief about common anorectal problems. Friends, all the anorectal problems constitute about 20% of our surgical OPDs, or in fact, all physicians' OPDs. The changing lifestyle of fast food, outside food, low fiber diet, sitting continuously, rising use of two-wheelers, and surprising now the younger generation is coming, especially from the IT sector, with lot of medical conditions. All this has brought into focus again the issue of proctology, and hence newer developments are taking place. It's a very brief review of the history of it's very old, right from the days of Hippocrates. Fistula was known and setons were used since then. If you'll see anatomy, in the surgical anatomy, only one thing is important, that it is a junction between ecto and endoderm. So the lower portion, lower half is lined with squamous cell epithelium, which is highly sensitive, while the upper half is lined by endothelium, which is insensitive. So whenever pain, everything occurs, whatever procedures you do, you have to remember to try and avoid the ectoderm. These are the common anorectal conditions. Piles we know as anal fissure, extremely common, followed by fistulas, anal abscesses.
Ravi, can you make it full screen presentation? The slides. Can you make it full presentation?
It is full screen on my laptop.
Okay. Sorry. Carry on.
Of course, there are malignancies, certain pediatric conditions. So hemorrhoids, everybody knows. These are swollen veins which cause pain, bleeding, prolapse. Fissures, extremely common, again, as I've mentioned, with changing lifestyle. Fissures leading to abscesses. Abscesses being infection of that anal glands, and which, if not treated properly or untreated, usually result in anal fistulas. Anal warts, HPV, infection, homosexuality. Pruritus ani is again a very disturbing condition. Anal stenosis, as rightly mentioned by our learned chairman, sir, quacks rule the roost. 80% of the patient have visited quacks before seeking a proper scientific doctor. And the treatment with quacks usually results in anal stenosis. These are piloneedle sinus is again one thing which is common in, as I mentioned, in younger generation, in IT sector, wearing tight jeans, sitting continuously in front of computers, rectal prolapse, especially common at the extremes of ages, anal malignancies. I would just, these are various anorectal malformations, congenital anorectal malformations, incontinence at the old age or post washed up surgeries. Anal tuberculosis is also, though uncommon, but it is still not that uncommon. Whenever we do a fistulectomies, especially in recurrent and multiple fistulas, out of 100 samples we send for histopathology, at least 5 turn out to be tubercular. These are the again various conditions. I am just enumerating them. Rectal foreign bodies, extremely common, working in the government medical college for last 30 years in the surgical department. I personally have encountered, you name the object and we have removed it, right from umbrella sticks to carrots to radish, anything and everything under the sun. People get perverse pleasure into it. I'm just running through the slides. I've tried to make it so that concise, what are the common symptoms of, by and large, the patient will present with perrectal bleeding. Either it will be a frank bleeding or a streaking on the side of the stools. Pain, post-defecation burning pain. Very common symptom, and this is usually the presenting symptom. Itching, irritation, perrectal swelling, and perianal discharge. These are 5-6 common symptoms which usually suggest that it is some anorectal condition. What are the common investigations? Of course, a perrectal examination along with proctoscopy, the age-old dictum, if you don't put your finger in the rectum, you will put your foot in your mouth. This holds true for all physicians, especially surgeons. Enoproctoscopy, now again, very good instruments have come where you can visualize the anus and the rectum. Colonoscopy is indicated in very few conditions, but very specific conditions. What has revolutionized is endoanal sonography with a perrectal probe. Practically, it has given us a great tool. Fistulogram, with the advent of MRI, especially for fistulas, fistulogram has now gone out of vogue. So endoanal sonography and a good MRI, especially very useful in cases of fistulas. Anal manometry, a very specific investigation to know the exact tone of the anal sphincter. Many times, we, before subjecting the patient of a fissure with lateral internal sphincterotomy, we do subject patients to a manometry so that we know exactly whether sphincterotomy is going to help. Again, the incontinence for difficography, electromyography, and of course, biopsy in suspected cases of tumors. This is for my non-surgical friends. Whenever patient presents with these common symptoms, what I term as a gunshot therapy. You need to give analgesics, of course. You need to give stool softeners. You need to give local ointments. Deworming is very important. Either albendazole, ivermectin, or a combination. In the pits, anal pits are very notorious to harbor dispose of these worms. Antibiotics, especially gram-negative, a nice hot water bath in the form of a sitz bath. Diet, extremely important, and a piles ring to sit on. This conservative management will take care of most of the symptoms in around 3 to 5 days, and the patient, because the patient was relieved from your symptoms. Just everybody knows what piles are, the swollen blood vessels, especially the veins. There are, as I said, various etiologies, physiological etiologies, pregnancy or any tumor, aging, diarrhea, constipation, sitting for too long, diet, non-fiber diet, heavy lifting, anal intercourse, overweight, genetics. If you go to the etiology, then there are two theories where one, the sliding of the fat pads, which causes shifting of the entire portion down, and hence many surgeries do advocate fixing up of the. How can you prevent diet, lots of fluid? Water is the best laxative. Remember, we tend to forget this simple thing. Water, as it is as good as diuretic, it is as good as a laxative also. And plenty of fiber. Fiber is going out of our diet. When we are blindly aping the Western diets, fiber is going out. Fiber was an ingredient, it was an inbuilt part of our traditional diet. All these are things where you can prevent piles. So lifestyle treatment, so many treatment options are available. But one needs to have a holistic approach in treating anorectal conditions. So lifestyle changes, medication we have already discussed. Hemorrhoidectomy, previously the gold standard was the open hemorrhoidectomy, the Morgan Milligan, where we used to just excise and keep that raw area, and the patient used to be worst for 2 to 3 months, and that has given a very bad name for pile surgery, in fact. Keeping those raw areas, then causing incontinence in some cases, causing anal stenosis in many cases. Now that has gone. Now nobody scientifically asked, nobody does a open surgery for piles. If you want to do a hemorrhoidectomy, then better you go in for a closed hemorrhoidectomy where you do a submucosal excision and then close down the mucosa. Stapler hemorrhoidectomy, that is the star procedure, was in fashion. Slowly, it has also gone out of fashion because of its various complications. So many minimally invasive procedures are available. As I said, one needs to have a holistic approach wherein we need to use the right technique for the right indication. So banding, again, banding, sclerotherapy, infrared coagulation, mainly used for grade 1 piles. Grade 2, grade 3 piles, you can use a radio frequency ablation or a laser surgery or Doppler guided hemorrhoidal artery ligation. Various procedures are again described. I am not going into those details. I would just like to mention our one Indian surgeon's procedure, Chiute's procedure, the transanal seromucopexy, which gives excellent results, especially for grade 3 and grade 4 piles. Anal fissures, these are small tears, extremely painful, extremely painful. Patient post defecation is in agony from 1 hour to 24 hours. He is unable to do anything. That much is the pain. These are the various etiological factors for fissure. Treatment, again, medical treatment with analgesics, antibiotics, and local medications. Nitroglycerin ointment combination with local anesthetic or combination with diltiazem, nifedipine with some steroid. You can do a chemical fissurotomy by using Botox injections. Surgery, again, like open surgery is barbaric. Doing a Lord's dilatation, which was at one time the gold standard. Unfortunately, still my surgical colleagues practice it. It's a butcher's job. I am very blunt about it. What is the gold standard is lateral internal sphincterotomy. You can do it submucosally, you can do it with RFA, you can do it with a simple blade, you can do it with laser, and the patient, it's a controlled sphincterotomy of the internal sphincter. You should not cut more than 1/3 of the sphincter, otherwise you will land yourself in problem. Anal fistulas, again a very difficult topic for us anorectal surgeons to treat. We all know there are various types. Broadly, there are low fistulas and high fistulas. In relation, they are decided as per their relation with the internal sphincter. As we all have studied, the external sphincter has no role in continence. The role of internal sphincter is very, very, very important in the maintaining the normal anal continence, and any damage to the internal sphincter will result in a hell of a life for the patient and the surgeon also. So again, so either the fistulas can be intersphincteric, which is the most common fistulas, transsphincteric, suprasphincteric, or extrasphincteric. Intersphincteric usually is low fistulas. Commonly, I am not going into all those Goodsall's rule and what is the pathology, but remember, 100% time fistula happens because of the infection of the anal gland, out of which 80% time the anal gland at 6 o'clock problem is infected. And if you not remove that infected gland, you are going to land with recurrence of fistulas. This is the latest classification. This is the etiology. As I already mentioned, in Western world, Crohn's is one of the common causes of fistula. We don't see Crohn's, extremely rare in our country. Tuberculosis is not that uncommon. So again, you will see that variety of treatment since ages ceton has been used. For last 2000 years, physicians have been using ceton. Ceton is you insert some foreign material, thread, catheter, whatsoever it is, from the external sphincter, from the external opening, and bring out from the internal opening, and then tie it with the hope that the tract will get fibrosed and will heal. Many times we go on tightening the ceton if it is a high fistula. So we cut the internal sphincter, but it is immediately healed, and slowly this procedure goes on from 6 weeks to 12 weeks. Fistulotomy, again, just cutting open, laying open the tract is the gold standard for treatment, even though so many newer techniques have come, but laying open the tract in low, simple fistulas, that is plain fistulotomy, will cure 99% of simple fistulas. Then this excision of tract can be done by so many other methods. You can use your radio frequency probe, you can use your laser, the lift procedure, so many procedures are there. Anorectal set is ligation of the intersphincteric fistula tract, that is you ligate the internal opening and then you use various methods to excise the remaining tract. So if you see the heading, balance between risk of recurrence and incontinence. A surgeon has to remember this. I would prefer a recurrence, but never an incontinence. This is what the patient has to be explained also, and the patient needs to understand also, and they understand it very well, that I don't want to land incontinent. I will be ready for second surgery, third surgery, or a combination of surgeries. So various you get now under video guidance, that is the WAF procedure, video assisted anal fistula treatment. You use a laser probe with it. You can use a glue or a plug, natural or synthetic, to plug down that. If it is recurrence 2-3 times, so many times we have to do a advancement or a reconstructive plastic surgery. So many things are available. Anal abscesses, again, as I said, usually they are the perineal abscesses, but very often you also get ischiorectal abscesses which are different from perineal abscesses. This is important. Challenges in treatment. Why the patient doesn't come? First and foremost is shame. Patient doesn't tell even his wife, or if he is unmarried, he will not tell his parents that I am suffering from such and such condition. Usually they ask their friends, and so many advertisements are there claiming for cure from everything under the sun, and they seek those treatment, or they know that they will change their diet for 3-4 days, take some laxative or some OTC product, and then the disease process remains there and it goes on progressing. The second important cause why patients are not seeking proper scientific treatment is misconceptions, and two main misconceptions. One is the fear of incontinence. As I mentioned, blocked up fistula surgeries and the previously two surgical procedures, one for fissure, the Lord's dilatation, and second for piles, the open procedure, Morgan Milligan. These two definitely had some sort of incontinence for few months, especially for gases and for liquids. And slowly with perineal exercises, even that used to go. But these are the two main misconceptions which the patient doesn't come to a proper anorectal surgeon or a general surgeon. One is fear of incontinence, and second, fear of recurrence. And hence, they go to alternative therapies. Ayurvedic people, Unani people, and most importantly, as I said, quacks. Every village, every locality of all towns, all cities, all metros will have in that particular area either a Bengali doctor or a Chansi doctor or a Rao doctor. Please don't take it otherwise, all Raos in Telangana and Andhra Pradesh. But everywhere you will find one of these doctors, and 80% of the time patient has visited one of these doctors and taken their treatment, and they apply anything and everything, and they do all sorts of things. I mean, I have seen these quacks applying hair of animals and tie weights to them and do anything and everything, and then lot of problems come. So this was in very short, and as I've mentioned first, the right technique for right indication. And if my all clinician friends are, everybody is well aware of the famous quote of Sir Hutchison, which is there in our medicine textbook also. From inability to let well alone, from too much zeal for the new and contempt for what is old, and from putting knowledge before wisdom, science before art, and cleverness before common sense, and from treating patient as cases, and from making the cure of disease more grievous than the endurance of the same. Good Lord, deliver us, that is, save us from doing all these mistakes. And if we follow this common dictum, I think we all will have a better world to live in. Thank you very much. Thank you, Dr. Vasanta Kumari and the entire IMA Telangana state branch for having me.
Thank you, Ravi Wankhedkar. Sir, You see, this
संजीव
is
रवि
become
भाई बोलो ना.
Ravi bhai, this has become a very important topic in our day-to-day life. Reason is many people have lot of dietary changes, lot of customization, lot of foreign food which has come into our day-to-day life. And Dr. Ravi has dealt with this topic. I think it takes a whole day for us to complete this topic. Nowadays, we have proctology conferences. The whole day we are discussing. It is something like a small mouth with 32 teeth, but this 1.5 centimeters of inches of anal canal is one of the most dangerous, devious way God has created, and the problems which exist with this are multifold. Dr. Ravi has given only the gist. If we can talk about fistula, it will take a whole day. If you can talk about the fissure, maybe half day, and hemorrhoids, one more day, pilonidal sinus, half day. This is how the status of the anal canal. I mean, he has not dealt with the rectum at all. But anal canal itself is a very, very vast topic to speak. And Dr. Ravi, being the professor, he knows where to put an end to this anal canal issue. Thank you very much, Dr. Ravi, sir. There are a lot of innovations, lot of machinery, lot of new techniques, and lot of ways where minimal access surgery has given people a new lease of life. Thank you, Ravi sir. An excellent presentation. You are always excellent. There is no need to talk about it. But I think I had a chance of listening to him in uh, Kozhikode, but I had to go to a temple. That is why I missed him. I think this is the first lecture I am listening to Dr. Ravi regarding the hemorrhoids. We will have a conference in IMA regarding proctology one day, and hope we'll do much better things to do in life. Thank you, Ravi sir, and thank you, Vasanta, and thank you everyone for being a part of it. I now request Dr. Vasanta to please carry on with the last ritual. Thank you very much.
Thank you, Sanjeev, for chairing the session. And thank you very much, Dr. Ravi sir, and all the audience. I would now request, if you have any doubts, you please write in the chat box, or you can unmute yourself and ask sir directly. Dr. Sampath, are you available? Dr. G. Sampath?
Good evening, sir. Dr. Srirang here, sir.
Yes, hello Srirang. How are you?
I'm fine, sir. Thank you. Wonderful presentation. A great learning experience for me as well. Just wanted to ask.
Go ahead, Srirang.
Where they used to dilate the anorectal ring as well.
Nobody does the dilatation, as I said. If you see the instrumentation with the minimal invasive surgery, that is itself causes some sort of dilatation, which gives us enough room to do procedures within that area.
Okay, sir.
And very rightly said by Sanjeev that I have dealt only with the procto part of it. I have not dealt with the coloproctology because today's talk was proctology. So I limited my talk to only the diseases of the anal canal.
Yes, sir. There used to be Dr. Pujari from Miras who used to do that procedure, I think, anorectal ring manipulation for fissures. So just wanted to.
Yes. See, now what we do for fissure, which is a gold standard, well established worldwide, is either at 3 o'clock or 9 o'clock position. We cut the internal sphincter around 1/3 of it, and it gives excellent results.
Okay. Thank you, sir.
Good evening, Professor Wankhedkar.
Yes, Sayed.
How are you?
Bhai, how are you?
Fine, sir. How are you? Very nice lecture, sir.
Thank
you. Very nice, quite informative in a very short time. I have one question, sir. Pilonidal sinus. Pilonidal sinus, sir. What do you recommend, open procedure or Z-plasty in your experience? You must have a lot of experience in pilonidal sinus.
Pilonidal sinus.
Now, is it the open procedure?
Yes, I got your question. Very nice question. Thank you for asking. Pilonidal sinus is one of a big headache. Whatever procedure you do, 60% will be your success rate. You will have to explain to the patient that 40% time you will have a recurrence. So either usually the patient presents to you with a piloneedle abscess in the first place. So simple thing to remember is to drain that abscess by a paramedian incision. Never take a midline incision to drain a piloneedle abscess. And once if he presents with a sinus, so many procedures are there, and you will find that so many times we have landed doing a Z-plasty or a reconstructive surgery trying to obliterate the natal cleft. But important thing is that you will have to explain to the patient that he has to remove his hair, take good care of the hygiene of that gluteal cleft, and proper follow certain basic instructions. So many minimal invasive surgical procedures are there. I am now regularly using laser technique and getting quite good results. But as I said, 40% of the time you land up with recurrence at some point of the time in patient's life, which we need to explain, and the patient also accepts it. See, basically what happens, if you see the etiology, the hair follicles go inside. And there are so many hair follicles there, especially in young males. That area is extremely hairy. And they tend to sit in front of computers, and then they slowly slide down. And this sliding motion causes the hairs to go inside. So if you see the etiology, it can happen and repeat any time. But many minimally invasive procedures are there, out of which one is laser. Open surgical techniques now we are avoiding because we keep it as a second option. And then if it is two-time recurrence, better do a Z-plasty or a switch a rhomboid graft. Thank you.
Thank you very much.
Ravi?
Yes, Akka.
So pleasant to hear you. And of course, being a senior proctologist and a dedicated teacher, you have really simplified, very much simplified from the basics and also to the updates. And I know it's more useful for the clinicians, the way you spoke, how to approach and all that, And it is so pleasant to hear from you after a long time. And congratulations, Ravi.
Thank you, Akka.
Okay.
Any questions from the audience? You're welcome. Dr. Sampath, are you available? No. Sir, we have been...
Congrats, Vasanta.
Thank you, madam.
Bringing Ravi, such a busy person, to this webinar. You must be really appreciated.
Thank you, madam. If there are no more questions, shall we close the session?
Yeah, please.
Yeah. Thank you very much, sir. I would like to have many more webinars from you, sir. Thank you very much.
Thank you. Thank you. Good night, everyone. Nice
Good
to
night.
see everyone.
Good night,
I
Ravi.
can see Dr. Anuradha from Bangalore also has joined.
Yes, sir.
Thank you. Bye-bye. See you in Hyderabad, Sanjeev.
Thank you, sir.
Bye, Vasanta.
Bye, Anuradha.
Bye.